Welcome to the Prescription for Admission podcast, where we talk about hospitals and hospital-based care, who you can expect to meet, and what you may experience during your time in the hospital, both as a patient and also as a healthcare provider working in a hospital. My name is Dr. Monique Nugent. I am a practicing hospitalist and also the author of Prescription for Admission, the book, where I talk about many of the same topics. Thank you for joining me and enjoy the show. Welcome back to what is the final episode of season 1 of the Prescription for Admission podcast. And I am your host, Dr. Monique Nugent, as usual. But today I'm actually joined by one of my favorite people to work with, and what I feel like is one of the most important people you need to know about in the hospital. And if you harken back to some of my conversations with the different people who work in hospitals, we talked to a psychiatrist, a hospitalist, an emergency medicine physician, pharmacist. And we also had somebody give her experience about caring for her loved one through her hospital stay. The important thread through all of this has been the case manager. Everyone has said case manager is really the person who helps tie everything together and helps people set themselves up for success after a hospital stay. And so we are joined today by my favorite case manager, Gena O'Hara. Gena, thank you so much for being with us today.
You're welcome. Thank you for having me. I feel honored that I'm your favorite. And
yes.
My favorite hospitalist alive.
So Gina and I both work at South Shore Hospital. We've worked together for years, and we've seen each other through different transitions of the hospital, different phases of patient care. We've worked together on, I feel like, every floor, even patients in the emergency department, patients in short stay. I do not work in the ICU, but I know that Gina's colleagues also work in the ICU. And Gena has worked with me for patients who needed a lot of care coming out of the ICU. And Gena brings a lot of really great experience. And what we're going to tap her today is really her take on why you need to know the case manager and how to get the most out of your interactions and your work with a case manager. So Gena, I always like to start with telling us what you do. What is a case manager for people who are listening who perhaps haven't heard that term before? Other facilities call them case workers. I'm sure you've heard people use that phrase. But what is a case manager?
So again, thank you for having me, Monique. So a case manager, the best I can describe it is we're kind of the middleman, kind of so much maybe like the navigator between home care, hospital care, acute care, observation care. I describe myself as kind of the middleman, like I mentioned earlier. We kind of bridge the gap. That's how I feel. Meaning, a patient gets admitted, it's South Shore Hospital, everyone gets a case manager usually. I mean, there's times when we just don't get to see one if they don't really need services post-op. I mean, once they discharge. However, but my role as a case manager is to make sure that the patient is supported through the whole process of being admitted and discharged. Now, wherever they go, discharge is the deciding factor what the case manager can and can't do for that patient. Mm-hmm. But I like to think, we bridge the gap. We're the navigator, we're the collaborator, we're the advocate for the patient.
Advocate is a huge word, because in my book and in my teachings, I talk about the fact that case managers are nurses. Mm-hmm. Right. And so you all understand the medical needs and can relay things back to the team. Like, hey, you guys aren't really noticing this, or like this family really cannot do IV antibiotics at home, or the opposite. Like, hey, we have a really high functioning individual here who can do wound care at home, who I think would be a good fit for VNA. Right. And understanding the resources of what's in the community, what people's insurance gives, and what they need, right? And like you said, bridging that gap, like where does it all meet in the middle?
I have just wanted to add, I should have added to that. I mean, I played many roles throughout my nursing career, and by far the case management role, I know some people who don't work in case management might not quite understand it, so here's a good way of understanding it. I personally, and I think most of our nurse case managers, I use more of my clinical judgment, my clinical skills as a case manager than I did when I was on the floor taking care of a patient. Not that that isn't important, because they do hard, tedious, very hard work. But being a case manager, you're more thinking outside the box. We're not just checking the boxes by saying, okay, this is the order, this is what I'm doing. We have to think globally, outside the box. What are the needs? And just like you mentioned, sometimes we collaborate with physicians and say, well, this is what their need is, even though they're the doctor. And 99% of the doctors will say to us, oh, wow, thank you. I didn't think of that.
Yeah.
So, yeah, it's definitely a group interdisciplinary effort. And again, using more of my clinical skills than ever. That's
Yeah.
what
So you just said you've had many roles in nursing. So how does one become a case manager? How did you get to this point in your career?
if I'm being honest. So myself personally, when I was a floor nurse, I should say, it was task oriented, very task oriented. And again, if you use Epic or not, the boxes are pink. We had to make sure they were blue. We need to make sure we check those boxes, check them off our list. And it can be tedious, to be honest with you. And after a while, it was just more task oriented. And after a few years, honestly, it's been so long, I can't remember, 5, 6, maybe 7 years on the floor. It took a toll on my body, to be honest. I've had a couple back surgeries, through personal things, but during my last back surgery, I decided, maybe floor nursing is just not for me anymore. So I looked into case management. I researched it a lot. I actually left the hospital and I was a nurse case manager at an insurance company. So I could get to see that side of it, which, right, you shake your head. It opened a lot of doors, a lot of lights, and wow, this is really how involved case management really is.
Yeah.
And then after a year and a half-ish of doing that, I did come back to the hospital as a case manager. And I will tell you, till this day, it's been my most rewarding position I've ever had. And I've been there, again, 15 years, maybe 12, 15 years. And I still love it. I will never leave it.
So case managers are everywhere, right?
Everywhere.
There's case managers in your primary care physician's office.
Yep.
There are case
Insurance.
managers when you write at the insurer. And we can't leave the insurer out of these conversations when we talk about planning for discharge and giving people the things they need to be successful. There are case managers at nursing homes. There are case managers at acute care facilities. So it's really important to know that there's somebody who can help you navigate, because our healthcare system in this country really has so many different ways to get lost, right? I've known really what you would think of smart people trying to get through a hospital stay and not know at all what was available to them, what they could do in the home, what they couldn't do in the home, what changes in their insurance would mean, right? And so really, this is where your case manager shines, because this is the person who puts it all together. I don't know, and I'm really open with patients, I don't know everything that's in the community. New nursing homes, new short-term rehabs, they open up, they close down, they get a new contract, they get a new ability to do this, to do that, right? And it all just kind of changes. And this is the person who will tie it together for you. So, Gina, tell us, when it comes to case management in the hospital, what does the public not know? And I know that's a huge, it's a huge question. It's a huge question.
Yeah.
But what is really left out of the conversation when people think about hospitals?
So, just like you said, it is such a huge question. And I'm going to apologize in case you hear a little bit of noise in the background. I'm in an office with a lot of activity every once in a while. There is so many answers to that question that I'll answer the best what I can. And it depends on the situation. What patients don't know for case management is, I'm just going to give you an example. It's just one little factor. So somebody gets admitted from the emergency room, and the hospitalist or the emergency room doctor or whomever will say, okay, we're going to admit you to a floor. We're going to admit you to a floor. We're going to keep you overnight. When a patient hears the word you're automatically they think, okay, I'm going to be inpatient and I'm admitted. The patient's they hear they're admitted. So then I come along sometimes and say, the next day or later that day, and I'll come around and say, oh, you're going to be discharged today. You had X, Y, and Z done. Everything was negative, and the doctor feels you're safe to go home. And, you were here under observation, say.
Yeah.
Patient gets confused and very, well, no, my doctor said he was admitting me, for the X, Y, and Z. And I say, yes, you were admitted under observation. And they don't quite understand that. And that's just one part, Monique, that I can say. It's one of the things when you walk in And then as a case manager, we have to go tell the patient, I'm sorry, your observation and you're being discharged today. They do tend to get overwhelmed or confused and say, well, wait a minute, what does that mean for my insurance? Again, where case management can come in and explain it.
Yeah.
So that's one part.
So that's level of care, right? That's something
Right.
that I
Yeah.
haven't touched on. When you come into the hospital, how sick you are really determines what your insurance agency and clinically like you need, right? So if you're
Correct.
super duper sick, you need a ventilator, you need a ton of medicines, you go to the ICU. But then there's this middle ground sometimes where like you are sick, maybe it's not fully safe to go home, you're not super duper sick, you might be able to go home pretty soon, but this is where the conversation between insurance agencies and the medical team come in. Is like, did you really need to admit this patient? And I don't like having honestly, I don't like having these conversations.
No one
because
does.
it makes me uncomfortable, because people sometimes feel that we are maybe doing these things on purpose or not giving them enough, right? And what people don't understand is in the background, the insurers have a conversation with Gina and her team and said, oh, we've reviewed all of this. And this is what we feel like is appropriate for what we will pay. And so we deem it this level or that level. And this is all part of that navigating, right? So yeah, people don't know that there's different levels of care when they come into the hospital. And I admit that at the medical teams, we use general terms like admitted. And those things are confusing to people. But also coming to the hospital and staying overnight is confusing because that's what people think as being admitted to the hospital, right? But I stayed here. I got breakfast. I had a bed. I had a nurse. What do you mean I wasn't admitted to the hospital as like a regular patient? Yeah, those things are very, very confusing. So reaching out because your case manager knows how to navigate that with you and your insurer is really key.
Yeah, and sometimes that is the more challenging part. Kind of explaining, well, even sometimes when you get admitted as inpatient and then after knowing what insurance companies require and telling a patient, I'm sorry, now your observation. And, it's very confusing and overwhelming to people that don't understand the medical field. And that's where a case manager comes in. We can explain that. And sometimes we have to be the bad guys, and that's not how we want to be portrayed. But then there's other times when we're total opposite. You come in and there'll be observation. We'll say, oh, no, he's definitely appropriate for inpatient, and we change that. But so there is so many multi-layers to case management.
Yeah. One of the things that I really encourage people to do with their case manager is I say lay it all out there. Be really honest, especially when it comes to time for discharge. We're talking about, hey, you may be leaving in a day or so. We think you may be able to go home tomorrow. This is what you need or you don't need. And so what I say is like, really just be really, really honest. This is what I need to be in my home successfully. And case managers work to make that happen. Can you talk a bit about the discharge? So we talked about coming into the hospital. What work do you do to help people when they're leaving?
So same thing, but opposite. That if, depending on the situation, and there are so many scenarios, and I'll give an example of maybe somebody needs IV antibiotics for 4 to 6 weeks being discharged. What, again, the average person who doesn't know the medical field or insurance, they may not know that they could go home with IV antibiotics, but it might not be covered under their insurance. Or they might have a very large copayment under their insurance versus maybe going to a nursing home to complete that course of IV antibiotics might be covered under their insurance. Again, it's all based on what type of insurance they have, how many days they have left, what coverage they have under, sometimes Medicare, sometimes commercial insurance. It's challenging. So when you have a patient being discharged and they just automatically assume, all right, well, I'm going to get all the services I need at home. And that is our role, to make sure that happens. If they need physical therapy in the home, we're going to get that, depending on insurance. If they need IV antibiotics in the home, we're going to make sure that happens. We never want to have a patient walk out that door without something being set up for follow-up care, because then we're setting them up for failure. So it is very challenging if you don't understand it. But that is our role, to make sure they do understand that. Make sure they know what's going to get covered. Do they need aftercare? Do they need physical therapy? Do they need speech therapy at home? Do they need IV antibiotics? Do they need rehab? Do they need a short-term rehab? Do they need an acute rehab? Do they need an LTAP, which is a long-term acute rehab? Are they new to hemodialysis? There is a process to everything we do.
Yeah.
Everything the doctors do. There's always some kind of aftercare that most people need when they get discharged from the hospital.
So I was once quoted as saying a hospitalization rarely makes things easier when you leave, right? And it sounds like that's the case. You're leaving with something else to do, right? It doesn't mean you're not going to get better, but in the interim, you may need all of these things Gina was saying. And it's amazing the amount of things we can do in the home. New medications is a big one. How you can access those medicines, making sure you can access those medicines. So Gina has chased me down many times saying, did you send this to the pharmacy to get cleared before the patient leaves? Because the last thing we want is that you leave and you can't access a medicine because the copay is too high. Or something that we do see nowadays is the pharmacy may not have it. We have recently run into different shortages. So like, nope, don't send it to that one. They're out of that. You have to send it to another place. And so
authorizations also.
Can you explain what a prior authorization is? Like, I feel like this is like the bane of everybody's existence in healthcare.
So again, it's depending on insurances. So I'll just use, I'm trying to think which one would require, but say if somebody has Medicare, or Medicaid, Medicaid versus commercial, could be Blue Cross, Blue Shield, United. A lot of medications require prior authorization. Like say if somebody needs an anticoagulation like Lovenox or Eliquis or Lovenox, which is a life-saving medication, in all honesty. Some insurances will, I'm trying to give you a quick example. Some insurances, especially if there hasn't been something tried prior to it, will deny it. So that's where case management comes in and we try to get authorization. Some of them even without form of trying something different before we go right to Lovenox or Eliquis. Some insurances just require prior auth because it's a high risk, high cost medication. Yeah. But patients, unfortunately, don't know that side of it. So when they get discharged, Monique, you discharge a patient who has new AFib and you say, well, he's going to have to be on Eliquis. That patient thinks, all right, I'll take the pill and I'll be fine. Then they go to get discharged and before they're even out the door, their pharmacy, because you've sent it to the pharmacy now, are calling them saying, okay, you can get this, but it's going to cost $800.
Yeah.
So that's where we come in. Again, we try to minimize those costs. We do what we can to get that, a prior auth or a discounted med. Most of the time we're successful in that. We have programs, we have things we can work with, but that is the issue. If that one patient gets out the door without seeing a case manager or without a case manager following up on these things, that one patient who gets out the door and then goes home and says, I can't afford $800, and they don't take it, and that's that. We never hear from them again until they get readmitted for the same thing.
Right.
So it's scary. This is where I talk about that multi-layer, that multi-collaboration needs to take place with a case manager on almost every patient. It's challenging, but it needs to be done.
Yeah. So insurances change their contracts around medications frequently enough.
Always, yeah.
That these changes need somebody who knows that, who gets the updates. I remember when Eliquis was expensive enough that we couldn't discharge people on Eliquis. And I specifically remember as a resident, I had a conversation, like a doc-to-doc conversation with an insurance doctor. And I was like, all this guy needs is Lovenox. It's going to cost you thousands of dollars a day to keep him in the hospital for this. Do you think you could? And it was like, nope. Have you tried this? Have you tried that? And that's really what the prior authorization process is the insurer saying, have you tried a bunch of cheaper options before you give them this more expensive option? And navigating that, I've tried prior authorization like on a weekend by myself.
It's not easy.
It's like you have to log into a system of I just gave up. It was really bad. And I felt bad because, like you said, people don't want these really large surprises. They shouldn't get these large financial surprises when they leave. And so, yeah. Can you tell us kind of the difference between rehab and a nursing home?
Yes. So it depends on what type of rehab, but short-term rehabs take place in a skilled nursing facility. We don't like to use the word nursing home because that scares a lot of people away.
Yeah. Yeah.
So before COVID, most skilled nursing facilities / nursing homes have a section in their facilities that kind of allot for short-term rehab. So that means, your 60, 70-year-old patient comes in, broke a hip because they fell, needs some rehab, more rehab that they could get at home. So we send referrals to these skilled nursing facilities, and if they have a bed and their insurance covers it, they allow a certain amount of numbers to come in for short-term rehab.
Mm-hmm.
However, again, people hear this and if they're not educated about it, it is a nursing home. It's a skilled nursing facility. But again, they're usually kept separately from the long-term residents. So they do their rehab. Now, and they get an hour and a half of therapies a day that could include physical therapy, occupational therapy, skilled nursing, like I said, the IV antibiotics, speech therapy if somebody's had a stroke.
Mm-hmm.
Hour and a half-ish a day through that skilled nursing facility who usually has their own PT, OT company come in. Or sometimes they have them on staff. They're all a little bit different. Now take a short-term rehab, which is, 2 weeks, 2 weeks sometimes, 10 days to 2 weeks stay. Sometimes longer, sometimes shorter. It depends on the patient, how well they do and how they can participate. Versus an acute rehab. So acute rehab, it's a different criteria you have to meet to be eligible for your insurance to pay for that. But at an acute rehab, you get 3 to 4 hours a day of aggressive physical therapy. So those are more for like your 60-year-old independent working person who had a stroke, who needs aggressive physical therapy, occupational therapy, speech therapy to get back to their baseline. It's your bilateral hip surgeries. Somebody needs aggressive physical therapy who was already independent-ish before.
Yeah.
I shouldn't say younger crowd because we've had 90-year-olds, 80-year-olds that break hips and they're more active than I am. So, but it's quite challenging, like I said, and you got to know that level of care as well. Like as a case manager, we know that. As a hospitalist, as smart as you are, you might not know that that's the level of care they really need.
Mm-hmm. Yeah,
So that's
it's that multidisciplinary between you working with the physical therapist, coming to the conclusion, coming back to us, because there'll be times where I will see a patient and I would have never seen them out of the bed.
Right.
I asked them, like, have you been out of bed? Oh, I go and I sat down to eat lunch and that's about it. And I will come and I'm like, Gina, this person is definitely going to need to go somewhere. They're going to need some rehab. They're, totally deconditioned. And then after physical therapy sees them, you meet with them, you meet with their kids. It's like, oh no, actually they can get up, they can walk to the bathroom safely. And that's like the most that they do at home. Right. So this meets their needs to be in their environment safely. Or, nope, you're right. We tried to get them up and they don't even qualify for acute rehab because they're not strong enough. They're still too sick. They still have wounds that need to be done. Their medication is still not fully stable. So like, can we come back and reassess them later? And it's that multidisciplinary conversation over and over again. So yeah, with your case managers, I say just lay it all out. What are your fears about going home or going to a facility? Oh, I've had a good experience with this. Our neighbor had a bad experience with that one. Really just say all of the things that you need because this is a person who can tie it all together for you.
Absolutely.
Yeah. So
if not, we can find the resources to make sure what is out there.
Yeah. So I was at the bank the other day and I ran into somebody who was like, oh, I kind of know what you do. And we talked a bit about her experience caring for her father with dementia. And she was really kind of stuck on the fact that he couldn't stay at the hospital. He had a fall at home and he was admitted and he was cared for. And she said, they just kept trying to discharge him. And I was like, well, he can't stay there. She's like, but he was safe.
Right.
And I feel like sometimes there is a feeling of safety and apprehension of leaving the hospital where people can feel like, I feel safe here. I'm getting the things that I need. I don't feel uncomfortable. Why are you asking me to leave? Yeah. And this one hurts my heart because it's a conversation I have on a daily basis that like, we cannot keep you here. But in addition to the fact that, people say, oh, it's because you need the bed. Yes and no.
Yeah,
Like,
hate that term.
hospitals need beds, but we're not concerned about this specific bed. But hospitals are not where people get better.
Nope.
And I
Sometimes
try
they get
to,
sicker.
they get sicker, and I try to really impress that on people. How do you navigate that? Because I will say that as tough as a conversation is for me, it's usually a once a day conversation. For you, it's a multiple time a day conversation
Yes.
because you have to reach out to them about the rehab and the insurance and the physical therapy result. Like, how do you navigate that conversation where people say, like, I just don't think I should leave because I feel safer here than going to the next place?
So this is a great question. Another one that's hard to answer a direct answer, but how I personally navigate it, and I know a lot of my colleagues the same thing, is first and foremost, myself as a seasoned case manager and anyone else who's good at their job, that I would never use the term that we need the bed, first of all.
Never. Yeah.
I would never use the term that, oh, well, you're being discharged. It's more of you are medically cleared to be discharged from this acute care environment. Because let's face it, South Shore Hospital and most other hospitals, they're acute hospitals. We treat the acute need. You
Yeah.
treat the acute need.
Yeah.
So, you come in with pneumonia, you get treated with IV antibiotics, you are better, your labs are great, your short of breath's gone, the wheezing's gone, whatever it is. So now you're medically cleared for discharge.
Yeah.
What the discharge looks like after that, that's where I think the confusion comes in with families. They think, just like you said, well, dad has pneumonia and he's not at his baseline. Perfect. Let's have this conversation. What are your fears? What are you worried about? Are you worried that he's going to go home and get sicker because he's not going to move around the way he normally does? Because we can set up physical therapy at home. Are you feel that he needs more medical care? Maybe some more IV antibiotics, a more closer supervision? Let's talk about rehab. Again, but knowing the multi-layers to this, it isn't just about, okay, you want dad to go to rehab. You want dad now to go to an acute rehab. But unfortunately, he doesn't have or fit that criteria for his insurance to cover that. I hate to say it, but it's most places are a business. Somebody has to pay the bill. You have to pay the bill where you're going. So how I navigate it, though, like I said, I ask them first and foremost, what are your fears? What are you worried about at home? Does he have the supports at home to help him get out of bed? Does he have the supports at home to maybe help him with his medications every day to make sure he finishes those antibiotics? If not, if he doesn't have supports, he doesn't have a wife, doesn't have children, doesn't have somebody who can be there with him, then maybe short-term rehab is the best option for him until dad can get on his feet, where he'll get a little bit more therapies to help him get on his feet. But first and foremost, that's how I started. Please tell me your fears. What are your needs? What is it you think you need to safely discharge dad? Because again, obviously I know case managers get a bad rep. We don't throw people out of the hospital. It's not how it really works. If they're medically cleared, yes, we find a suitable discharge plan for them.
It is really hard because there's a lot of fear. Like you said, there's a ton of fear coming into the hospital. And then you work through that fear. You finally get comfortable with the thing that's happening. Or maybe you're not. Maybe you're not comfortable with what's happening in the hospital, but you're working on a plan. And now you may have to renegotiate what life looks like after a hospital stay. And so it can be multiple steps even after a hospital stay. So we work with a lot of older people, and people will come to the conclusion during a hospital stay, like, mom can't live alone anymore.
Right.
Dad can't live alone anymore. But you can't go from a hospital to like a long-term custodial. And by custodial care, I mean someone who helps them do the things they need every day, dressing, eating, bathing. You can't go from a hospital to that. There's so many different steps.
Normally, yes.
Yeah, and there's so many different legal and financial implications of something like that, right?
But we can help navigate that as well.
Yes,
That we
I was
don't.
about to say. And this is where your case manager can help you understand what's coming down the road. One of the favorite things that I hear patients say, or a patient's family member say, is case manager has said that I should get something called an elder care lawyer. Do you know what that is, doctor?
I do.
And I love that because it shows, again, that case managers are this bridge, right? They're the medical bridge, the social bridge, and oftentimes the legal bridge, right? Saying like, oh, wow, I noticed that this family is going to need a little bit more
Right.
the navigating and a little more planning going down the line. And I love when I hear that because what I hear is my case manager has noticed what we need and is helping us for the future. And it's all about success after discharge. Yeah, and so, again, case managers are, I feel like, the rock stars of the hospital. And they're also very specialized, understanding what's in the community and what people can do, what people can't do. I can't tell you how many times I come to Gina and I'm like, I got a plan. And she's like, that sounds wrong. And I'm like, okay, like, tell me why. I'm like, okay, I think this guy can go home with this. And she's like, he cannot do that, Monique. Like, he lives alone, or like, oh, his pain is still really a problem and his family isn't comfortable with him being at home with pain, or like, we think he can start eating again in a couple of weeks. And so can we send him someplace that can do repeated speech evals, right? So a hospital stay isn't where you're going to get better.
Right.
A word Gina used is acute, which means short term, the thing that's happening now, right? And what happens in a hospital is that like physical therapy can't do those 3 hours with you a day. I often hear people say, well, physical therapy came and walked my dad down the hall and back, and that was it. And I'm kind of like, yeah, that's the crux of what goes on in a hospital. I think TV does like a really bad service because on TV, physical therapists have like treadmills and weights for people.
We do have some of that somewhere.
We have like,
not every day.
Yeah, not every day. That's
Right.
outpatient physical therapy. Inpatient speech therapy looks very different. Inpatient, everything looks very different because we're about like this short term. What's this thing happening now? How do we get you safe now? How do we get you out of pain now? How do we make a plan? And moving forward out of the hospital is where you'll start to feel better and start to recuperate and make those changes that you need in your life. So when you see your case manager, please, or if you haven't seen your case manager, wave them down.
For them.
Ask for them. This is the person that's going to help you tie. If you are a caregiver, the case management team is going to be really key to help you figure out what you can continue to do and get after hospital stays, because things change, right? As someone's condition changes.
Even with insurances and like Medicare rules are a lot different from Blue Cross Blue Shield. Those are just examples. But yes, it changes all the time. The laws change, resources change, criteria changes.
Mm-hmm.
So, and we need to keep up with all that. So that's our role. That's our job. We have a lot of team meetings. We keep up with a lot of the ever-changing needs. But yes, but you're right. And unfortunately, case management is the best, I have to say, but I can't say that we know everything because sometimes we just can't help, but we can definitely guide patients and families in the right direction. We can get those resources they need. The outcomes aren't always the ideal, but 99% of them, I hope they are.
Yeah. So physicians and nurses, case managers also can specialize, correct? People who have really specific medical needs, like transplant patients, they work with really specialized case managers, right? There's case managers who work in the community, case managers who work with people with developmental delays. And so you may find that you might have a case manager through your insurer already for whatever reason. So personally, I had a child who was a preemie, and when we were discharged, we got home and there was a letter that was like, here is your case manager assigned from your insurer, because preemies need things after a hospital stay, right? They have to get their hearing evaluated, and we went for repeated speech therapy and things like that. And so our insurance agency had assigned us a case manager already, somebody whose job it was to follow us and make sure we were able to navigate the system after that discharge.
Insurances do have that, Monique, and I think most people don't know that. Even if you're not sick, there are case managers through, I would say, almost all the insurances that you can be set up with, and they can help navigate, especially aftercare. If you didn't get something in the hospital, or if a case manager didn't quite set that up, you can call out to your insurance companies. And there are sometimes, to be honest, especially with specific programs like PACE or frail elders and things like that, the case manager in the hospital when you're there, the acute visit you're there, normally talks and communicates with your case manager in the community, in your insurance company. And that helps too with the continuity of care. You leave here, you rest assured, if you have a case manager at your insurance or in the community, we'll collaborate with them to make sure your discharge is successful.
That's a really great piece of advice that
Yep.
even if you're not hospitalized, you can just call your insurance agency and say, hey, can I get a case manager?
And again, I don't know every insurance, but the majority of them do have them.
That's awesome. That's an awesome piece of advice. So getting into pieces of advice, I always ask my guests for their top 2 tips for patients and family members when working with someone in your profession. So what would be the top 2 tips for patients and family members when working with case management? My number 1 tip is open, honest conversation. Lay all your fears, your abilities, your inabilities, your concerns, your preferences, lay it all out so that they know what they need to do to help you with the next steps.
So I would have to agree with that. Number 1 is communication. Like the old saying goes, if I don't know what's broke, how am I going to fix it? If you need something and I don't know what your needs are, if you're not upfront and honest and tell me what you're looking for, I can't help you. Most of us are not mind readers. So very first one is open communication. Always be honest, be upfront. Other one, it gets very complicated. It's very open-ended. It depends on the age of the patient. It depends on their insurance, but know what your insurance has to offer. Because again, I'll give a quick example. If you're 85 and elderly and you live alone and you're getting early onset of dementia, we know that eventually you cannot live alone anymore. So know what your insurance has to offer, because most people do not have long-term care insurance. There are a few who have it, but it's highly costly, and usually the people that have had it their whole lives. So know what your insurance is, know what you have. Please, if you can do it, always try to have a secondary insurance. That is very helpful. Some people don't have that. I mean, at a certain age, you might not need a secondary, but once you hit, the elderly stage, and I'm probably going to be considered elderly too, but that secondary insurance is important because that helps offset some of the costs for hospital stays.
Yeah. That's a great piece of advice, is planning for the future by knowing what you have right now.
Right.
Right. Because I will agree, I don't think most people know what their insurance agency offers. I think it's kind of the opposite. I think people always assume more than what they have.
Yes. Most people think they're covered 100% everywhere, and it's realistically, that is not it.
Yeah. I mean, the fact that we as a society, a culture, have decided that healthcare is funded the way that it is means we have to have these conversations. And that's kind of the crux of what I do, is just this. I'm telling you the truth. And the truth is that your insurance agency may not cover everything.
Right.
And so know what you have and plan accordingly. That's a great one. And I like that other one, that your insurance agency can have a case manager. I was not aware that, for
It
almost
might not
everyone.
be all of
That's
them,
awesome.
but most do.
Yeah. But again, if you ask and the answer is no, you're in the same place where you've been.
Exactly.
Right. And so what's the pain in asking? So wonderful. This has been a fun conversation, Gina. Gina and my conversation are always fun.
Yes, it is.
So before we started recording, I said, we always talk about what is your favorite medical show that depicts your job, but I don't think case managers are really depicted in Hollywood, television and movies. Nothing that I can really think of where a case manager, what I see is social workers. Have you been seeing this show, The Pit, that everyone's been talking about?
That's what I was going to tell you about that one. Yes.
Yeah. So they have a social worker there who I think they write to kind of act like a case manager, but a social worker and a case manager are two very different people in different roles.
They are and they aren't. So they are two different licenses, two different fields, I agree. But in some cases, social work and case management can work so closely together that they almost seem the same. To, again, somebody who doesn't know the medical field.
Yeah.
Again, not making light of my position or a social worker's position, because they're very important. They're so important.
Yes.
But there are certain things, you mentioned earlier about different hospitals have different names for them, and they do. So, especially the skilled nursing facilities, I think they call them all social workers. Mm. So that gets challenging to know that difference. But social work and case management work so closely collaboratively together. Like in our department, we work together for things. Some people say call the social worker, see what rehab you're going to do. Well, that's a case management position. Call the social worker I'll call the case manager to do a long-term care application for Mass Health. That can be case management, but social work helps with that as well. So it's very different, but yet the same, if that makes any sense.
Yeah.
But going back to your riddle thing, the pit right now is one of my favorite ones because it's other than the last couple episodes, is realistic. They're very realistic, and I love that the head doctor really respects the nursing part of it. So I love that in that show, but you are 100% accurate. I cannot recall any kind of medical show, maybe once, but that elaborate on case management. I don't think I've ever even heard the word case manager be used in one of the shows except social worker.
Yeah. I've only made it to like episode 3 of the pit.
Oh, I'm way up there, so.
Yeah. I keep telling my husband that we'll watch it together, and then we don't, and I'm about to leave him behind.
It's a little more realistic than most of them, so I liked it,
Yeah, I thought it was good. And so, I know there's supposed to be lots of drama coming down the pipeline, so I'm excited to get into it. But if I ever write a medical show, man, I'm going to put case managers in there. I cannot tell you the different ways I've worked with case managers over the years. One of my other most favorite case managers was at the VA. And that's a really specific system to work in because they have a lot of things within the system. And
great place. Again, a lot of people are afraid of the VA, but they offer so much. People, if you're a veteran, please, by all means, find out what you can get. If you're service connected, again, that's another whole podcast, but VA offers so many things that people just don't know.
Yeah, it's really true. And she was great. She used to come to our rounds in the morning. I think my favorite part as a resident is that she always made breakfast, but you couldn't get your muffin or whatever until you cleared your list with her.
I love it.
And she'd be like, "All right, let's go through all the patients. Okay, now we can eat." But I mean, it's a little fun. And in working in hospitals, we have to be collegial and find ways to make the work a little bit more light. But the case management, to me, the rock stars of the hospital. So if you are ever in the hospital waiting to be admitted in the emergency department, there's tons of case managers stuff that goes on in emergency departments. Please ask to speak to your case manager.
And you're right. It starts right in the emergency room. We have a great team down there as well. Sometimes there's so many patients in the emergency room, it's hard to get to, but it does start from the minute you walk in that door to the minute you leave.
Because it's all about success after discharge.
Yeah.
Think about that. What do I need to be successful in the community, safe in my home, getting back to the things that I want to do? And Gina and her team can help you do that. So I want to thank you, Gina, so much for joining me for this conversation. Like I said, there's a reason why I asked her to be our season closer, because we have spoken so much about case management throughout this season that I wanted to hear it from my favorite case manager, but also, to me, one of the most compassionate and thoughtful case managers I've come across with over the years, who really understands the system and can speak to you about what she and her team does. So, Gina, thank you so much for joining me today.
Thank you for having me, and I truly feel honored, Monique. You know how I feel about you.
Yeah.
So thank you. It's been an honor and a pleasure, and if I can help in any other way, please let me know.
This is fun. Maybe we'll have you back. This is
hope
really
so.
exciting. Awesome. Well, this has been the Prescription for Admission podcast. Thank you guys for listening to season 1. Remember to hit the button to like and subscribe and follow us. And there will be more to come over the time to learn about hospitals, who's who, what's what, and how you can improve your experience in a hospital. Thank you so much. Bye.
Take care.